Okay, here we go. This video is going to cover an overview of the 2016 diagnosing. I will do another video to cover the actual guidelines and that kind of thing. But this video will cover an overview of the ICD-10 manual and the conventions, kind of how to read it, how to find your codes, that kind of thing. Then I'll do a second video specifically to the guidelines. Just like on this CPT manual, if you do not thoroughly understand your guidelines in any of these manuals, but particularly the CPT and the ICD-10, you will not only fail the board, but you probably are not going to pass a coding test to get a job. And everywhere has coding tests for jobs. I'm telling you, everywhere. I take them all the time because I'm always trying to leverage into different areas so that I can keep my skills up, so that I know what kind of jobs are out there, so I know how difficult some of the pre-employment tests are, so that I can relay that information to you guys. So here we go. This is what mine looks like. I love Carol Buck. Believe it or not, I do. She was not necessarily my favorite person 6, 7, 8 years ago, but I love the way she has her manuals. I like some of her textbooks. I think she's very good. She's very good from a learning perspective. And I just kind of I think she's the guru of the editions. So when I can, I always make sure that I get a Carol Buck edition of the ICD-10. It used to be ICD-9, which was, in my opinion, a much easier manual, but now they've changed it as of October 1st of 2015. So all of the ICD-9 videos that I have, unless you're coding HCC, you're coding across multiple years, or workers' comp, you probably are not going to do you any good. I wouldn't even bother watching them, because if you're coding real time, then everything is ICD-10 as of October 1st of 2015. This is a huge manual. My screen is not that big, so I'm going to have to do quite a bit of moving around and stuff, and I'm sorry for that, but just kind of bear with me. I'll get through it the best I can. As you can see, so we'll be tabbing this manual as well. As you can see, I have multiple tabs. I personally chose to tab all of my alphabet just because I had to learn and get used to this manual just like you guys are. This was new to everybody. I think I became an AHIMA ICD-10 train the trainer back in 14. Nope, back in either 13 or 14, maybe 14. Back when we were supposed to implement in 14. But then they postponed it for a year, and it really didn't implement until 15. So there you go. Maybe it was 13 when I became a trainer. I can't remember. It doesn't matter anyway. So here is the manual. I use the professional. Now, I know some of the folks that I work with use an expert level. And expert has a whole lot of extra stuff in there. Probably really great information actually working in the field and maybe working for a facility or something, and you need all that extra stuff. For us to learn, it's too much. It's just too much, and you generally, so I like either the standard or the professional edition. You should, you only have 2 volumes in here. If you've heard scuttlebutt about the 3rd volume that the ICD-9 used to have, it doesn't have it anymore because that volume 3 was the inpatient procedures, and they've gotten taken out of the manual, and they are in their own manual called the ICD-10 PCS, which is the procedural coding system. So we're doing just diagnosis codes, the clinical modification for ICD-10 used in the US. Okay, so let's crack this bad boy open and see what it has for us. And I think I can, for the most part, I think maybe we'll be okay doing it this way. Whole bunch of advertising, that kind of stuff in the front. Here's a section much like the Hicks Picks. I'm hoping I get that kind of centered. That kind of gives you a breakdown of how to use the book, the different symbols that you'll see. We will go over that as well. How to use the includes and the excludes, the code first, the code alsos. This book, in its essence, is written, in my opinion, perfectly. It's just we as humans don't read it perfectly. So if you follow all the commands of this book, you should be able to 99% of the time come up with the right code once you get, fully acclimated to it. Again, just like the Hicks Picks, some pages here to kind of get you used to the layout of the book. It's a great reference to go back to. Starting on page 1, I have a tab here. This is where the guidelines start. Page 1, and I'm going to move it over just a little bit. Okay, so your guidelines are all of this red section. That is your guidelines. Goes to page 48. You need to tab it today, and this is the area that I'm going to do an actual video on. All of these guidelines. We will go over those guidelines. Just like the other manuals, we do have pictures. They are great. I can almost swear to you, I've been a nurse 210 years, and when I took the board, I referenced the pictures. So there aren't any of us that are too good to not use the pictures. I would rather see it and confirm what I think is true than guess on the board and miss it because I wasn't reading right or something. So these are great pictures. Some of them are some of the same pictures in the Hicks Picks, but some aren't. Okay, just a great reference. I would recommend you in your medical terminology and that kind of stuff, make notes on your picture pages. You can write in these manuals as long as it's pertinent to the manuals. So put in as many notes as you need to. So what if 6 months from now you're like, oh, why did I put that in? I know that. Well, you didn't at the time. So notes are good. There are still notes that I write in all of my manuals that I know the stuff, but I put it there because the one time I look at it, maybe I don't know it that day. Maybe I forgot it or something. Okay, starting on page 81 is the alphabetic index. Alphabetic index. For the purpose of this manual, unlike the CPT, remember when I was teaching you the CPT, I told you to absolutely stay out of the index because I hate it. You can't be dependent on it. You'll never really be able to master the CPT if the appendix is a crutch. It is opposite with this manual. You have to, by rules in the guidelines, you have to go to the index first, look up your code, and then you verify your code in the tabular, and I'll show you how that happens. I gotta get my cat out of here. You hear her little bell? Okay, so this is the index, alphabetic, and there is an art to how to look stuff up. You will get very frustrated. That's just the way it is. We all have gotten frustrated. But all of these gray pages, you can see the different letter. All of these gray pages are the index. So once I go through the book, we'll come back and talk a little bit about how to look things up. And especially in the next series of videos that I do when we get into advanced coding and we're actually looking at scenarios on all these videos, I'll be able to walk through better with you on how to find certain codes. So that's the index. Next tab is on page 455, and it's the neoplasm table. I just put neo, but this is the neoplasm table. The neoplasm table in the ICD-9 was actually in the index. This one is not. They still have it, but it's not. I will come back after I get through the book, and we'll talk about the neoplasm table, how it's divided up and all of that. But right now we're just tabbing, kind of getting an idea of what all is even in this big book. From the neoplasm table, you have a table of drugs and chemicals. This is for poisoning. This is diagnosis codes. This is not where you go to get the actual substance code. Remember, that's in our HCPCS. These are diagnosis codes of poisonings or adverse effects, whatever, of the drugs that either we took and had an adverse effect, or we took and we weren't supposed to. This is on page 505. 505 is our poisoning table. It's a big table. On page 695, 695 is our external cause of injuries. These are what we used to call E codes, external cause injury codes. They're not E codes anymore. They're actually V codes now, which is funny to those of us who know the old system. But this is just label it. We'll talk more about this. Then we start our tabular. So we had our index volume, and now we have our tabular volume. And the tabular is where you go to find the code that you found in the index. It's where you go to verify. So you find your code in the index, you look at it, take that code, go verify it back here to make sure that you have the right code, or you don't need to add digits or something like that. Now, I have a slew, and I'm not sure if you guys are going to want to tab it like I did. Generally, in the ICD-9, I didn't tab much in here. I mean, they're just numeric numbers. From an ICD-10 standpoint, they're just alphabetic. So if you found a D code in the index, then you just take the tabular to your D code and find it. For me, after not having it tabbed, I chose to tab all the different letters. ICD-10 is different from ICD-9. It starts with a letter. Every single code starts with a letter. ICD-9 did not. It started with numbers. You still have your 3 categories, like with ICD-9. Before the decimal, you have your 3-digit category code, then your decimal. But whereas the ICD-9 only went 5 digits, your ICD-10 can go up to 7 digits, either letters or numbers long, your codes can be. So it's a little more involved. For you guys, you don't know the other system, so it's not going to be that bad. You won't have to, oh man, that's how blah, blah, blah used to be. So it's not that big of a deal. So I am not going to take the time and go through each of these A, B, C, D, and all of that. If I were you, follow your colors. Label your colors. Okay? That will get you in the ballpark of everything. Just see what your colors are. I will tell you that your color red is actually C and D, so you just have to kind of thumb through them. But on your own, not on this video, go through and get your the different colors coded on your own. Now, let's kind of start. Well, let's see. Let me find an easy code for ICD-10. Just a minute. Let me. Bear with me. I don't find many easy codes in. No, that's not going to be easy. I'm going to show you some of your. Here, we'll do diabetes. which actually is much easier in ICD-10 world than it was ICD-9 world. Across the bottom, I am on page 824 and 825, but I'm actually the very first page of the E codes, E08, in chapter 4, E08. So if you don't have my same edition or publisher, then you can get here, but it's the diabetes. That's where we're starting. And we're just going to kind of overview, learn how to read the book. So I'm going to move this and hope it doesn't slide completely off. Here under E08, beside it I have a red stop sign. And if I come down to the bottom of the page, you can read all of the definitions for all the different symbols and colors that you see. So we're just going to stay on this page and talk about what we see. So if you see a code with a red stop sign beside it, you have to add a digit to that code. You cannot code E08. That is not a valid code. So the stop sign is telling you you need to add a code to it. So then you come on down, E080 added a code to it. It added a code to the E08, but it still has a red stop sign. So then you have to go indented underneath it, E0800, no red stop sign. So that's our first valid code on this page. So down here, the red stop sign means use additional character. If you look at E08.2, it has a red stop sign, but underneath it, we have lots of choices. So we don't have to go any further than our 21, 22, or 29. So the red stop sign anywhere in this book says you have to use an additional character, period. You have to. Under E08, you have a little aqua highlighted that says code first. Any time you see code first, there's something else there's another code you're gonna have to pick up, and it's gonna have to sequence in front of this code. So here, in order to code diabetes due to underlying condition, the book is telling you that you have to code first that underlying condition. Makes sense. So they're giving you some examples here of what the underlying condition is. Most of the time, you can find what you're looking for here. So then you would code the underlying condition first, then come back and code your diabetes. Then your yellow kind of beige highlight says use additional code. And it said for this specific one to identify insulin. So that means that you have to code first this underlying condition, then you're going to code from here, then you're going to pick up an insulin code if the insulin's being used. So far, generically for this book, we're staying on one page, but these are generic rules across the board. If you see a red stop sign, you have to find additional characters, additional numbers to go with it underneath. If you see an aqua code first, you have to go find a code first, sequence it first, then code from here. If you see a use additional, then once you followed the code first, the red stop sign, the use additional comes next. So that's telling you you're sequencing. All right. We're going to take just a second and look in the guidelines. I didn't necessarily, well, not necessarily the guidelines, but it is going to be way back in, it's Roman numeral 10. And on this particular page, there are two things that I want to point out. The excludes 1 and the excludes 2. Here is the definition of the excludes 1 and excludes 2. This is new to ICD-10. We used to only have one kind of excludes. So on this particular example, we only have an excludes 1. Your excludes 1 is, if you have experience, is the same as the excludes in the ICD-9. It means anything listed here, you can't code with what's here. You can't code them together. You got to pick. You either code from here or you code from these excludes. You go someplace else. The two cannot be in the same place. We'll come up with the excludes 2 examples in a minute. So let's turn to another page and see. I'm going to try to be kind of random. I'll give you the page number in a minute, but it's hard to be random in this book, I'm telling you. I just want to kind of go over what we just did in a different place because these rules are going to apply everywhere. Let's see. Surely some J codes. Let's see. Here we go. I'm on page 991. 991. If you look at code J44, I'll give you a second to get there. This is code J44. It is other chronic obstructive pulmonary disease. Has a red stop sign. So that red stop sign immediately tells me I have to look down for more. I have to add a digit to it. So J44 is not a valid code by itself. So then I'm looking at either J44.0, .1, .9. There's no red stop sign. So these would be the actual COPD codes that I could choose from in this category. We have we do not have a code first here, which we've already looked at. We do have an includes. And what the includes does for you is it helps give you some of the lingo that you may be seeing in the doctor scenarios. So maybe instead of just plain old COPD, the doctor said chronic obstructive asthma. Or they said chronic bronchitis with emphysema. Or chronic obstructive bronchitis. These are other lingos or other ways of writing this diagnosis that are included in this area. So the includes is a great way to kind of see what might actually be included in with this disease process. We have a use additional here. Use additional code to identify, and then it gives us some stuff down underneath here. If the patient's a smoker, if they've been exposed to secondhand smoke, you know, different scenarios. You do not have to use a use additional if the scenario does not apply. If the patient's never been a smoker and never been exposed to secondhand smoke and never worked anywhere to influence him, no environmental anything, then skip it. It doesn't pertain to your specific scenario, but the use additional is just a reminder to you by the book that, oh, if you're coding in here, if any of these apply to you, make sure you're picking up that code too. Here is an excludes 1. Excludes 1 means you cannot code any of these with this section of codes. The two cannot be together. So then it tells you if your doctor actually wrote chronic bronchitis, not chronic obstructive bronchitis, then you need to go someplace else and get your code. It's not here. That's what that excludes means. Excludes 2. Now this is on that Roman numeral 10 page, and we haven't covered this yet. Excludes 2 means you can code this with this code. Just make sure you have the documentation to prove it. The 2 can coexist. They can be together if need be, is what that excludes means. Okay, so here's your excludes, and this is something that lots of folks get mixed up, even people who are training for one of the companies that I work for, believe it or not, can't seem to get this straight. Under asthma, that's a J45 with a stop sign. Under the excludes 2, which means you can code them together. Excludes 1, no way. Excludes 2, you can. Then you can, if your scenario is asthma with COPD, then you can code your asthma over here and you can code your COPD. Whereas in the ICD-9 world, those were a combo code. They are separate here, and it would take 2 codes to code them. Please, please keep in mind, this is just an overview. If your head's swimming right now, it's okay. It should be. It's okay. Practice, practice, practice. That's the only thing that gets you coding adequately is practice. Okay, here's a new one. Code also. That means if you're coding COPD and this patient has asthma too, you're supposed to go pick it up. So then you come over here, pick up your asthma. We already knew from our excludes 2 that we could code them together, but that's just another bit of information that proves to us this book's 10 times smarter than all of us, I promise you. You will believe it once you get into some of the codes. It's a very, very smart book, and we default to it all the time. So that's just a second way for the book to tell us, yep, you're right. If you read that excludes 2, you can code an asthma and a COPD together. All right, let's look at some other unspecifieds. You see this purple unspecified here. In theory, ICD-10 was created to be a more specific diagnosing system. Unfortunately, the world is full of unspecified things. So, although we have significantly cut down on unspecified codes, there are still some unspecified codes in here. And again, you can only code what your doctor documents. So the doctors will eventually learn how to document better because they're going to get denied on stuff. And eventually, if not already, any doc that submits unspecified codes may be getting their claims denied. Depends on what the code is. If you submit a claim for a right ear infection and you documented a right ear infection, but you billed an unspecified ear infection, you're probably going to get that denied because there is a specific code for a right or a left ear. Let's go to those. Let's go look at those. Those are H codes. I don't have exactly memorized, maybe H66. Oh, I don't use these that often, so if I'm wrong, just, it's okay. Hard to have all these memorized. Oh, I am right, H666. This is on page 931. I had hundreds of ICD-9 codes memorized. I have very, very few ICD-10s. Nobody can have these suckers memorized, at least not yet. Another couple of years and we'll probably be doing pretty good. Okay, so let's just generically look at this H code. H66 on page 931 has a red stop sign by it. That tells us we have to, it's not a valid code and we have to add a digit. So then we come down here. H66.0 still has a stop sign. So we keep going down. H66.00 still has a stop sign. So we keep going down, and here are finally our H66 codes that don't have a stop sign. And if we look at them, they are very specific codes. One is right ear, left ear, bilateral, recurrent right, recurrent left, recurrent bilateral. Then at the bottom we have our recurrent unspecified and our just unspecified. So if the patient has a acute suppurative otitis media, acute suppurative, which is pus, purulent, that's not clear fluid in there, otitis media, that's an otitis, inflammation of the ear, specifically the middle ear. Remember, there's three parts. You have your outer ear, external, middle, and inner ear. So this is the most common, specifically that middle ear. Say they have a acute suppurative otitis media of the left ear. You would have to code H66002, acute suppurative otitis media. You have no mention of this rupture of the tympanic membrane or rupture of the eardrum. Left ear, same thing. Tympanic membrane, eardrum, same thing. Okay, so say we know it's of the left, and it should be code H66002. If that doctor bills as an H66.009, which means he's saying unspecified ear, the insurance company is going to deny that claim because you did not code as specific as you should have, and there was a code for you. That's what I'm talking about. Okay, so since we're here, let's read these notes again. We just did the stop sign, so we know how that stop sign stuff works. Includes. So suppurative and unspecified otitis media includes lingo, suppurative and unspecified otitis media with myringitis. Remember when in the CPT manual, when we were in the ears and we were talking about a myringotomy and a tympanostomy, that they were the same thing? This is the same thing too. This would be inflammation in that middle ear. And so they're saying that if you have this lingo, it's included in this area, so you're good to go. Your use additional means if any of these smoking codes apply to your situation, it's just reminding you to go pick them up. Use additional means they're going to be sequenced behind here. Use additional means I coded here, now I'm going to code something else. So that's indicating for you your sequencing. Sequencing does matter, sadly. Let's see, I'm going to slide the book over. Hope you don't get motion sickness from all of this silliness. Okay, let's look at H62, top of that second column, H62. Again, we have stop signs, red stop signs. Those stop signs tell us we need additional characters. So we go to 62.4, still a red stop sign, so we have to keep going down. So in category H62, we have 4 codes to choose from, the 40, 41, 42, and 43. This particular area is telling me I've got to code first for an underlying disease. Hopefully the doctor has listed it for us. If not, we're probably in trouble. But if they do have the underlying condition for this category, then we would code it first and then code in here. Again, do not code an unspecified ear if you have documentation of a right, a left, or a bilateral. Don't do it. Don't do it. Okay? The little half moon, sideways or half circle on all of these mean they're a manifestation code. It tells you right down here, which means This patient has some underlying condition, and this is the manifestation side effect of that underlying condition. Keep in mind, everything that I'm telling you on this video applies to the entire manual. I am only using these as examples. So anytime you see this yellow half circle, you better sit back and think, now what's the underlying condition? If this is a manifestation, something has to be causing this. So that's why you would code first something. It's just a way of thinking. 7th characters. Let's get to, here we go. There's bound to be some 7th. Okay, I'm on page 1274. Code S14.2. Holy moly. Okay, page 1274, code S14.2. And this particular code is an injury of nerve root of cervical spine. It has the red stop sign, and it has an X by it. That red X means it is a placeholder. And that placeholder is always used in the 7th, let's see if we can, in the 6th, sorry, there's 7 characters. 6th, let's get back to this page 10, or Roman numeral 10. I told you we were going to be moving around. This is growing pains. Please, please, please just kind of stay relaxed. I promise we will practice this so much you will know this like the back of your hand. Here's Roman numeral 10 page that we were on. I'm actually looking here under the X. It says for codes less than 6 characters that require a 7th character, a placeholder of an X should be assigned for all characters less than 6. The 7th character must always, be in the 7th character place. So this is where you have the actual definitions of these. So let's go back to that 1274 page. And I'll get there, maybe not as fast as you. Okay, 1274. Back to our codes here. So this S14.2 is only 4 characters. And the 7th character, look at this blue box here. Actually, let's go backwards, because you always go backwards. You can't go ahead, because this is S15 category. So anytime you need a 7th character, you have to go back to the S14, or back to the first of the category. So on page 1273 is actually our S14 category, and here's our blue box. And it says the appropriate 7th character is to be added to each code from category S14. So this blue box is where you pick your 7th character. So A for the initial encounter, D for the subsequent, S for the sequela. So let's just stay right here on this page. And let's look at the concussion. S14.0. That is 4 characters. You have to get to 7 because you have the red X. And for the 7th character, you're going to have to choose, was this the data service you're coding now? Was it the initial time that the patient was seen for this problem? Was it a subsequent encounter for this problem? Or is it a sequela? For those of you with ICD-9 experience, sequela is late effect. Is this a residual effect of a previous accident? And that's a sequela. So let's say code S14.0 XXA for initial, or if this is a sequela of the concussion, then it would be S14.0XXS. Okay? Little confusing. We will have plenty of little short exercises to do this. Okay, a few more coding conventions down here, and I'm kind of going to centralize this. If you see a green sideways triangle, that just tells you it's a new code. Does it matter to you guys if you haven't ever seen this manual before? They're all new to you, so what do you care? The weird blue arrow revised, same thing. What do you care if it's a revised code? You didn't know the previous one. Deleted obviously is a line through and deleted. We've gone over excludes 1, excludes 2. We've gone over includes. That's just the lingo in the list. We've gone over use additional, code first, code also, and unspecified. We've gone over our placeholder. We've gone over our stop sign. And we've gone over our manifestation code. So we have just about gone over everything, at least a very cursory going over. The OGCR, those are the official guidelines. You may see those different places in the book. I actually don't pay any attention to them, so I couldn't tell you where they are. But that's telling you that you're coding it based on, it's probably coded weird. Actually, let's go back to the front. I feel like I'm making you guys go through preschool here. Sorry about that, but I mean, it's better to know that we've got proof of everything that we're, oh heck. Where did that go? Here's that Roman numeral 10 page. That's where I'm trying to get to. So if you get there before me, good for you. Okay, here we go. Again, where we found our X, there's the OGCR. The official guideline symbol includes placement of a portion of the guideline from where the actual guideline is found. So they're just citing. It's kind of like citing, like a footnote. Some of the codes have that. And Coding Clinic, we don't even have an OCR, a definition of that. But when you see this Coding Clinic, all that does is tell you that in the official how to use the codes Coding Clinic, that you have to pay extra money for, that only a select few people can pay the huge amount that it costs. They're citing in here what the rule is, that you code it this way based on a Coding Clinic rule. For us, the OGCR and the Coding Clinic doesn't really matter in here. We don't have access to that stuff. We're just going to code it based on our guidelines and based on our book. Just the old-fashioned matching up how we use it kind of stuff. When you actually get working, maybe you'll have access to Encoder Pro forever and you can get into that Coding Clinic, or maybe your hospital has access to it. It's a very nice feature to have, especially if you're auditing, because that's where all the little hidden, unwritten rules come from that you just slowly kind of tailor your coding to. So it's nice to have. Okay, so we have gone over all of these symbols, and I'm just making a mess of this, aren't I? I'm sorry, that is really a heavy book. On the bottom across here, these are the easiest ones, because if you see an N, that means they're newborn, so they're under 28 days old. Pediatrics, 0 to 17, that's 29 days to 17 years. Maternity would be 12 to 55 in theory. Adult, 15 to 124. Females and males. That means if you see these symbols by a code, that's the only group of patients that code's good for, which keeps you from putting a prostate on a female or putting a vagina on a male. Those codes are obviously gender specific. A male cannot have one. Well, I guess they can now, but anyway, we won't talk about that. The book is telling you what group of people that specific code is good for. So if you don't have any of this criteria besides your code, then obviously that code's good for anybody. Could happen. These are fractures, dislocations, and stuff that anybody can have those. Those are not gender or age specific. Okay, so far in this video, we have tabbed our book. We have gone over all of the bottom conventions. We've seen it in practice a little bit in our codes. We kind of maybe know what these blue boxes are. We kind of maybe know how to get rid of our stop sign and kind of maybe know how to do our placeholders. So for now, go with this information. This is just good basic information. On the guideline video I do next, I will actually go to OB and show you how you have to pull up some extra codes based on the guidelines and how you're going to code your hypertensions with your chronic kidney disease and that kind of stuff. We'll get a lot more specific. But for now, this is just the basics of how to navigate through your... Oh, wait. That is not true. I told you I was going to go back to these tables, and I'm gonna. Good thing I started flipping. Okay, so let's go to your... I was almost done, but you're stuck with me a little longer. Here is the neoplasm. It starts on my page 457. Okay, this is the neoplasm where after the tabular, here's the tabular end. This is the neoplasm table. So all neoplasms, whether they are malignant or benign, will be in here by alphabetical body part. Across the top, you have malignant primary neoplasms, malignant secondary neoplasms. You have cancer in situ. Remember, in situ means in original place, in situ. You have benign neoplasms. You have neoplasms of uncertain behavior, and you have unspecified behavior. So I think we kind of know all of these. Let's talk a minute about uncertain behavior. A neoplasm of uncertain behavior, that term will come from the pathologist. It's not that your doctor doesn't know if it's benign or malignant. The tissue has actually gone to the pathologist, and the pathologist says, I cannot determine what the behavior of this tissue is going to be. I cannot for certain say it's going to mutate into full-fledged malignant, but I can't say that it won't. So the pathologist, at whatever state that tissue is in, mutation state, cannot for certain determine what the behavior is. Unspecified behavior, although I think it's valid to have to use this on very rare occasions, your insurance companies don't like it. They want you to tell them, is it malignant, benign, what is it? So unspecified behavior, I think will be used very, very rarely. Now, in order to get the correct code, if you're not told it's malignant, then assume it's benign, assume it's normal. You have to code completely based on the information that is documented, whatever the doctor documents. So this whole table here are body parts. So let's do one. Let's do kidney cancer, malignant kidney cancer. So I don't know if you can find it under kidney. Let's see. Let's look and see. It's alphabetical. You really have to kind of watch what's indented underneath. It's kind of hard to read sometimes. I'm trying to get to K for kidney. Okay, you guys are probably already there. Hold up, I'm getting there. IJK, kidney. So a malignant kidney would be C64, and then it has that dash. That means we have to go verify it. It's not a full code. So let's go look. Kidney C64. So let's go back here. Remember, we always verify. To C64. Let me get my Bible. Okay, so I go to C64, and I'm on page 784. That C64 has a stop sign. I already knew I had to add stuff to it because it had a dash in the table. So I have a choice from 1, 2, and 9. C64.1 is the right kidney. C64.2 is the left kidney. And C64.9 is the unspecified kidney. So there again, you just plug in what information your doctor's given you. So if it's cancer of the left kidney, malignant, then it's C64.2, and that's the code that you would use. And that's how you use that table. I'm almost done. Okay, now let's look at the poisoning table. Sorry about that. Okay, the poisoning table starts on page 505. Looks very much like the neoplasm table. All here is all the different substances that you could possibly be poisoned by. Every kind of drug that they can give you, recreational stuff, poison under the counter in your sink, whatever it is, it's here. Then you have different categories across the top. You have your poisoning accidental. You accidentally took it. You did not mean to take that arsenic, and now you've been poisoned. Intentional self-harm, you would only code that if the physician gave you that information. You do not want to say someone's trying to kill themselves if they're not. You have to have the documentation to back you up. Poisoning by assault, that could be a roofie and a club some night. Poisoning undetermined. An adverse effect, so the doctor gave you this medicine to take, and now you had an adverse effect to it. You took it right, it's just an adverse effect. And then underdosing, this is brand new, this is not a part of 9. If the physician gave you that medicine to take and it was underdosed, then you're still having the issues or problems, or there are more now since they're not being medicated. So that's how you use this table. You just plug in your drug and then pick your category. Across the top, you see external cause T codes. These used to be those E codes from 9. If you're experienced in this, all of these would start with an E. Now they start with a T. Same type of usage, just looks completely different. So that's how you would plug that in. The external cause, I am not going to talk about that this video. I'll talk about that on the guidelines when we cover the what used to be V codes that are now Z codes, and what used to be E codes that are now T codes. Most of these are T, well, there's some U's and W's and Y's, and they're just all over the place for E codes now. Okay, so now now we're done with this. That gave you a brief overview, gave you a little bit of information if you were experienced with 9, what some of the changes are, stuff to look for. And the next video we'll go over specifically the guidelines, and then we'll specifically go over the E code index, and probably a couple of specific areas, especially OB, because there's an extra weeks code that we do now along the way.